Doesn't matter. I don't want us to differentiate ourselves. We spend too much time differentiating ourselves, and in that we get into a weeds that the client and the physician don't even care about.
I guess I appreciate the distinctions that we all have. Like, I want to be understood from my sports medicine viewpoint versus I want to be understood just from this pelvic health lens.
When I reached out and said, would you hire an OT? Can OTs do this work? It was resounding from the people that I connected with. Why wouldn't we? Why wouldn't we welcome someone passionate about getting trained and serving this population?
Because obviously, like, I come from that approach of like, the more the merrier, the more people who can know from within their scope, like, let's do this thing. It's going to take all of us to make like systems, population level changes. And we've got to be able to have conversations with one another and not be afraid from saying the quiet parts out loud that sometimes we might be scared to say because we might step on people's toes.
What we need to do is recognize where our own strengths exist as an individual therapist, provide those strengths as needed, and where we can't meet the needs of the client, refer out to those who can.
There's been a lot of discussion specifically on the role and scope of practice of occupational therapists in pelvic health. And what I want to do is really broaden this discussion to include all disciplines, because there's so many disciplines that practice within the pelvic health therapy field. But we're going to focus on two main disciplines tonight: in rehab, occupational therapists and physical therapists. And what I want to do is really have an open discussion, have a standard panel. They're going to be our standard panel that you're going to see throughout this evening, having a discussion. We're going to roll guests on. And we're super excited that one of our guests is the esteemed Dr. Alyson Stover. She's the president of the AOTA, and she's going to speak to the role and scope of occupational therapists within pelvic health. I want to give you a little bit of background before I invite my panel members up to discuss the very title of this talk that's brought us all together, and that is pelvic health therapy. Some would actually consider this a controversial title because it really doesn't distinguish the unique professions that practice within pelvic health. Should it have been pelvic health occupational therapy? Should it have been pelvic health physical therapy, and then collaboration across the two disciplines that we're obviously speaking about? Does pelvic health therapy actually confuse those in our profession as to what our unique differences in our roles are? From my standpoint, I worked in multiple settings, one including inpatient rehab back in 2004, 2005, when I was actually a rehab tech. And I watched occupational therapists really dominate. I'm going to use a term that I've actually heard in the past few weeks, but I actually use this term intentionally to just say, from my perspective, I saw occupational therapists dominate in the pelvic health therapy field. In 2009, I was a rehab tech in an inpatient unit where a young woman was actually recovering from a C6 spinal cord injury, and she wanted to work on her sexual health, her perineal care, her pelvic health. And guess who was dominating in terms of her care in that unit? It was occupational therapy. My own mother, 3 months before I started PT school, had a massive stroke. And the person that actually probably the most intentionally treated her pelvic health and addressed the mental health, especially around my family members, of her inability to control her bladder, her bowels, and really address the sexual health changes that she experienced after her stroke was, you guessed it, occupational therapy. And this was all before I actually learned about pelvic health therapy in PT school. So we're going to talk about pelvic health therapy, pelvic health rehabilitation across all disciplines, across all settings, and have an open discussion. I invite with me my co-host tonight, esteemed colleague. I really, really have admired Laura Rowan's work. Laura, will you introduce yourself and your practice?
Yes, my name is Laura Rowan. I'm a pelvic health occupational therapist, 16 of my 24 years of being an OT. And thank you, Rebecca, for having this discussion, because when I first met you, I was drawn to you because you led with OTs, right? As a DPT, you you were speaking to OTs first, and you speak so eloquently, like you just did, as to why, and have the backing for it. So, I treat pelvic health clients, all gender diversities, and I also am very passionate about being able to share the work and spread the work and advance the work for all clinicians, right? All clinicians, medical and wellness professionals, because the field itself is the work, and then we are all supporting it. So it took me, you can imagine 16 years ago was kind of an island as an OT, and I didn't get into the field because I wanted to be a trailblazer. I got into it because my OT brain said this is where I should be. And it only made sense to be doing this work in this field. And so I think that's why I have such a drive and passion to be working collaboratively, because I was raised by pelvic health PTs, right? That's who's doing this work. That's who saw the vision. When I reached out and said, would you hire an OT? Can OTs do this work? It was resounding from the people that I connected with. Why wouldn't we? Why wouldn't we welcome someone passionate about getting trained and serving this population? So I'm really excited to have this conversation. I went internally to be able to spread the awareness within our OT profession a few years ago, and we have made amazing advancements. And we're going to hear from the amazing OTs that are supporting this and all the advancements that we have made and continuing to make, but really to be able to work collaboratively to reimagine and to continue to advance the profession as a collective. So thank you.
Excellent. Welcome, Laura. Thank you so much. Now I would like to add a guest on, very esteemed colleague, Dr. Julie Wiebe. Thank you for joining us tonight. Please introduce yourself.
Hi, everybody. I'm Julie Wiebe, and I apologize. I lost my voice, so this isn't a microphone problem. This is a me problem. But I'm very grateful for the opportunity to be here. I actually, when I started talking to Dr. Seagraves, I was just amazed with what she was suggesting related to acute care. And I felt like, holy moly, this is this total blind spot that we've had in and around our community in terms of caring for those immediately postpartum. And so I just reached out to be like, go, this is amazing. We have a huge blind spot. And I think, and that created an opportunity to keep learning from her. And so I really appreciate the places that we can serve that don't look like the traditional outpatient definition of maybe a pelvic health clinician. And so I am a physical therapist, but I'm actually a sports medicine physical therapist, an orthopedic physical therapist in terms of my background. And I am not a traditional pelvic health provider. I don't do internal pelvic health. And I, many, many years ago, started trying to suggest that we could do both, that these were complementary skills that I could offer sort of an external sports medicine eye on pelvic health needs. And so, and really have basically spent my career trying to look at variables that affect pelvic health outside of the pelvis. And so that includes all sorts of things. And the longer I'm here, the longer I learn that there are so many things. I spent the day steeped in pediatric literature today. And it's really, there's just so many more elements to this than just the pelvic floor. And so I'm actually coming, and I've been very transparent with Dr. Seagraves about this. I'm coming to suggest, like, I teach, full transparency, I do teach courses, and I have OTs on those courses all the time. I have other professions on that there as well, SLPs. And it's because there's this, it's all connected. It's either all connected or it's not. And I really have sort of a whole person care viewpoint that's systems based. And so the reason I say that is while I appreciate I guess I appreciate the distinctions that we all have. Like, I want to be understood from my sports medicine viewpoint versus I want to be understood just from this pelvic health lens. I want my distinct, unique skills and gifts to inform my practice. Like, that's what I can offer in referrals. That's what I refer out all the time. So I'm sort of coming in to this with the acknowledgement, or the like, collaboration is 100%. Like, if we all have that same goal and intention of caring for these needs in multiple populations, like, we should all be doing that. But I actually think the distinct skills and gifts that we each bring enhances our abilities. And so that's sort of the perspective I'm coming from. I'm also coming in to represent the kind of confused about some of the things that we're seeing out there and trying to understand this better. I'm really here to ask questions and learn. So
Absolutely. And I want to give a little personal background. I discovered Dr. Weeb's work in 2014 when I was still in PT school, just learning about the physical therapy role in pelvic health. I assumed that a lot of pelvic health was done by occupational therapy. And if those of you are joining us in the middle of this, rewind to the beginning when you see this later. So because I'm explaining a lot of my perspective of pelvic health to me, especially when my focus was so on the acute recovery of people after surgery and those in the hospital. I had a really deep passion for acute care. I thought pelvic health therapy was just occupational therapy. I thought the terms were interchangeable. And so our last panel member tonight, I would love for you to introduce yourself, Kelsey, and just add to this conversation, round out the discussion, because we will be bringing up Dr. Alyson Stover in just a moment, the president of the AOTA.
Awesome. Thank you all. It's such a privilege to be here. I also discovered Julie Weeb in 2014. And so this is an honor, and just like sitting with Laura, who's done so much for continuing ed for OTs, and you, Dr. Seagraves, just like, it's an honor, truly. So like, first and foremost, thank you. I also want to give a little shout out to Lindsay Vestal, who really wanted to be here, but is traveling in Europe right now and couldn't make it. And so she sends like her regrets and wishes she could be here with us. I am a pelvic health occupational therapist since 2015. Fell in love with pelvic health on field work. So like, my first introduction to pelvic health therapy was on field work with a level 2 in my first level 2, and just Krista Covell-Pearson did such a fantastic job. And when I saw all of the different components of OT lens applied, like, I was sold hook, line, and sinker. I knew it's what I wanted to do, and it's where I belonged. And so now I've come through a variety of different paths, but I work as a contractor for the U.S. Army. I have to give a disclaimer: none of the views I expressed tonight are that of my own, are the government. They are my own. Sorry. But what I do is I love systems level change, and I work at a population level. So I used to run a private practice, but now I work population level of interventions that we can do for pregnancy and postpartum physical training from a holistic, whole person perspective. And I travel around the United States and internationally training Army leaders, not just practitioners, but also practitioners, on ways that they can approach and engage people across the spectrum of pregnancy and postpartum. So it's a little bit about what I do, but I'm really looking forward to hearing what everybody else has to say, because obviously, like, I come from that approach of like, the more the merrier, the more people who can know from within their scope, like, let's do this thing. It's going to take all of us to make like systems, population level changes, and we've got to be able to have conversations with one another and not be afraid from saying the quiet parts out loud that sometimes we might be scared to say because we might step on people's toes. And I'm confident tonight that we can be respectful as we discourse this. So I'm really excited.
Excellent. Thank you all for joining us. So those of you in the audience, before we bring up Dr. Alyson Stover, I want to just kind of bring forth a question that's been really ruminating around this discussion, and just acknowledge the fact that we've now heard from a physical therapist myself, whose kind of beginnings of pelvic health therapy were from observations as a rehab tech within the inpatient environment. And in that inpatient environment, I'm just going to say this word because I think it really does put the perspective on who I considered, from my own clinical and my lived experience, who I considered dominated pelvic health therapy. I thought those were occupational therapists. We've also heard from an occupational therapist who leads a continuing education program, Essential Pelvic Health, Laura Rowan, that she was raised by pelvic health PTs. So she considered her practice really culminating from the trainings and the education she received from our sister discipline, physical therapy, or her sister discipline. We heard from Dr. Julie Wiebe, who has been teaching and preaching that there's so many benefits to really applying external approaches to pelvic health. She doesn't consider herself an internally a practicing pelvic health therapist. And so she's bringing that perspective from the sports medicine world that really rounds out our discussion of just the different populations and patient presentations that we're all trained to treat. And now we have Kelsey Matthias. Again, you are teaching and you're practicing at such a systems level. I can't even tell you the goosebumps that this gives me because of most of you know my passion around Black maternal health. You know my passion about the number one surgery that's performed in the world. The number one major surgery is mostly performed on Black bodies, and that's cesarean section. And so even if we were to collaborate tonight, and this would be a beautiful discussion and call to action, and we're now working as a team of occupational therapists and physical therapists, there would still not be enough of us to treat just that patient population after C-section. So I just want to kind of frame this discussion tonight. And as we invite Dr. Alyson Stover, I would like to ask the first question and then have my panelists follow up with questions that they have. But there's been a lot of talk that at the association level of the AOTA, American Occupational Therapy Association, and the APTA, is that there's not enough either support, involvement, clarity on the distinction between our roles of occupational therapy practitioners and physical therapists of our role in pelvic health. We don't have any clear guidelines, definitions, roles, scope of practice, all of that. And we need our AOTA and APTA organizations to be involved in this discussion. So I say, well, why don't we bring them to the table? The invitation has been put out to APTA. We may have someone, maybe a special guest, join us who's representing the APTA. I'm fingers crossed, really hopeful that within the next 90 minutes that we still have someone join. But we actually have the president of the AOTA joining us to actually speak on behalf of the organization. And so I'd like to, without further ado, bring her up to the stage. And Dr. Stover, if you can put your camera on, I can see you and then pin you onto our panel tonight.
Thank you. It's an honor and a real privilege to be here. I appreciate the invitation, and I am thrilled to hear so much of what's going to be shared.
Excellent. Dr. Stover, if you wouldn't mind, and we're all going to talk, I prepared my panel, and I said I want this to be like The View. And obviously, anyone watching this, they're going to probably say, well, she's Whoopi Goldberg tonight. But I would love for everyone on the panel to kind of use this time and ask you questions. But what is your knee-jerk response to saying, we want our organizations, we want our association, our leadership involved in defining our role in pelvic health as physical therapists and as occupational therapists? What's your knee-jerk reaction to that?
So my knee-jerk response has changed. And I'll say right now, my knee-jerk response is, yes, absolutely. We need that. I will say that a year ago, maybe a little over a year ago now, that my knee-jerk response was, but how? Right? I had the great fortune and opportunity of having a number of occupational therapy practitioners who are in the pelvic health space enlighten me, educate me, give me opportunities to shadow, ask questions, learn along next to them, and learn from them. And I will tell you that that has been vital in changing how we are able then to address it from the national association level. The national associations, they very much, they're us, right? I'm an occupational therapist. I'm in a volunteer position. And that means that we are the ones that need to inform the national associations on how and what needs to be done. we working together and having such incredible voices coming from the pelvic health community in OT have been able to move forward a position paper on pelvic health and OT. And I do want to give a shout out to Dr. Carlin Rayum, who I'm not sure if she's on, but she is brilliant, incredible, and absolutely amazing at so many things. And one of them is really leading the initiative to write with a group of others. I believe Dr. Ellis is on here and is in the group as well, working on creating a position paper for occupational therapy in pelvic health. And that's really one of the first places that you start, right? You have to write the words down, and they have to be written down at the national association's level. So figure out, what is the entity? What is in AOTA? It's through our RA. So you go to your RA rep and you tell them, and you know what? You go to your board members and you tell them that they should be hearing about this from the RA. And then you go to the people that are in other states with other RA reps and you tell them to go to their RA reps. In APTA, it may be a different system, but there is a system, there is a department, an avenue in where these products are formed. Go, ask, no, demand. The words have to be written down. From writing them down, that's where we can spiral into advocacy, reimbursement, better awareness, training and knowledge to referral sources, the interdisciplinary community. But we can't do it until the words are written down. So my knee-jerk response is, you are the experts. Write the words down and then make us publish those for you.
Panel members, I don't know how you cannot like get out of your seat after that. To me, it's like, I think, Dr. Stover, if I were to just kind of restate what you said for the audience listening to this later, is that we are the APTA. We are the AOTA. Am I understanding you?
Absolutely. These organizations, they exist for us. And APTA and AOTA are where our professions are defined. Who do you want to define your profession? I want to define my profession. I walk out every day into my clinic and I work with children that some people think, I didn't know OT could do that. Well, they need to, because I know what that family and I experienced together. You know what you and your pelvic health clients experienced together. You know what you and your acute care client that needed a pelvic health intervention experienced together. Write it down. Define your profession. Don't let someone else do it.
And just to speak to, I mean, Alyson has moved me to tears before, and the support. So, about a year and a half, 2 years ago, we were a voice, and we were saying, yes, we are here and we can do this. And we hit a lot of roadblocks. We hit a lot of grief and pressure, but with the right support, especially Dr. Alyson Stover, and the right people listening, people heard us. And again, taking the time to take your family to these different clinics and really immerse yourself in the lives of the pelvic health OTs that are doing this work. It shows in your passion, in your speeches at conference, and your ongoing support. We have communities of practice in the AOT. We have communities of practice at state levels. We have Practice Act memorandums coming out, and now thankfully a position statement to help be a launching pad for everything else to fall in place.
Just to play the devil's advocate, Dr. Stover, I have to say for the pelvic health physical therapists in the room, I'm trying, y'all, really. For the pelvic health physical therapists, there's been a little bit of a concern of the communication. How do we differentiate the role if we're saying that occupational therapists have been in this field of practice of pelvic health since the dawn of your profession. Well, how are we differentiating this for the public to understand who they're going to be treated by? Should that be coming from the AOTA?
That's a great question. And I'm going to give you an answer that may surprise you. So I want to tell a story that actually starts in chronic pain management. Chronic pain management in the 70s and early 80s was actually an interdisciplinary type of intervention. You went to a chronic pain clinic. At that chronic pain clinic, you saw physical therapy, you saw occupational therapy, you saw a physician, usually a pain specialist, sometimes a neurologist, you saw a psychiatrist, you saw a social worker, you saw a counselor, you saw a recreational therapist sometimes. And we had outstanding outcomes when this interdisciplinary team moved together and really provided what is, I call, truly holistic care, right? We all as health professionals say we look at the whole person, but in reality, I can only look at the whole person through my OT lens. I need my PT colleagues to look at the whole person through their PT lens. It's not that any one of us doesn't look at the whole person, it's the lens in which we are viewing that whole person that is different. And so what happened? Well, what happened is the world of pharmacology created some pretty powerful medicine that, mind you, was being used in these interdisciplinary clinics, but they got together with our reimbursement sources and they said, hey, look, this could be kind of expensive, this interdisciplinary. And so, let's cut it all back because we could just give a pill. And why do it's so much cheaper, right? But what do you do? So what do you do? So first they stopped reimbursing for the recreational therapists, and then you saw the social workers leave. Then the OTs were gone, then the PTs were gone, right? The psychiatrists were gone. But in order for us to be gone, we couldn't make noise and advocate. And in order for us to not make noise and advocate, we had to be distracted. And so what you did is you saw the introduction of words like scope creep. So now I'm arguing with the PTs about what I can do versus what they can do, instead of arguing with the PTs that we should have never been taken out of chronic pain to begin with. This is what I say when you say, how do we differentiate ourselves? Who cares? Stop differentiating yourselves. We are valuable. You know who's going to know best if they are with the right pelvic health individual? You. So who cares if the physician refers to PT pelvic health and that person really needs OT pelvic health? Because that PT pelvic health therapist is going to know that and going to make sure you get there. Who cares if they refer to OT pelvic health and they need PT, or if they need both of you together? We don't need them to refer to discipline specific. We need them to refer for pelvic health complaints. So it doesn't matter. I don't want us to differentiate ourselves. We spend too much time differentiating ourselves, and in that we get into a weeds that the client and the physician don't even care about. What we need to do is recognize where our own strengths exist as an individual therapist, provide those strengths as needed, and where we can't meet the needs of the client, refer out to those who can. We need to work with one another. We need to embrace the gray that we practice in, not be afraid of it or try to fight it. No, it's beautiful when PT and OT walk next to each other. You know when greatest outcomes are achieved? In an interdisciplinary environment where rehab professionals are united and walking in the gray. You know when outcomes are not achieved? When we're too busy at the granular level, making sure that we're practicing just the OT aspect or just the PT aspect. I'm going to tell you something. You are all trained with a lens. You actually don't even realize that you're using that lens anymore. So the differences we can't see because they're natural to us. But that's what we're bringing to the table. I can assure you that there's not going to be this overtaking of an entire scope, because the OT doesn't have the PT lens and the PT doesn't have the OT lens. So let's not define it. Let's not get granular. Let's say we can do this together. Let's just get the clients to us.
I like that. I like that, because who are we defining it for? I think that's a question I have. When we have to define, I did a little research, like under hand therapy. What's the definition? What's the difference between OT and PT hand therapists? And I gotta say, I don't think either of us would be very happy with what the delineation was. It's so flat and it leaves out so much because it's such a complicated answer, right? We have so much that is so wonderful that we bring to the table, but to put that into words for a client, because that's who we should be thinking about. Who are we defining this for? The client, so they have clarity. Let's just call it pelvic therapy, or let's just make it simple so we understand the language, but keep it clear for the clients.
Thank you so much, Dr. Stover. Dr. Weave.
I just want to jump in because I heard that, and I probably heard it through my PT lens. And yeah, I was like, yes, but my conclusion is maybe a little bit different, or maybe not even conclusion, which is, I'm not suggesting the distinctions. I think the distinctions are fighting over what it should be called, or, like that might be that advocacy that you're sort of talking about, that granular piece of the puzzle, versus the way I heard what you were saying, Dr. Stover, as like the distinct lenses that we have. Really, that is beautiful to enhance it. And I know, as someone who works in sports medicine with a sports medicine lens, I do bring a different lens to the situation. And I actually would prefer not to be identified, as I said, with maybe just my pelvic health skills, because then the sports medicine people don't listen. So I also think it's that there's, I think that the way I heard what you were saying was, let's not distinguish it, but more so that we can all just serve our client. Because I honestly am not sure that the public is confused, in the sense that if that's really who should be deciding who they see. Are they getting results? Whoever they're seeing, are they getting results? And that goes for me. And if I am not getting the results, I am more than happy to refer out. I know the edges of my skill set, and I know the edges of my scope. And scope may be a dirty word. I've never heard scope creep. I was like, wow, that's like, I want to know more about that word or that term. But I think that, I guess I'm going to call it skill set. I know exactly that this is not for me. And I think I'm coming from a perspective of teaching across multiple skill sets. Like, I work with folks in adult neuro, pediatrics, pelvic, postpartum, ortho, sports medicine. And so each specialty knows their population like that. And so I sort of feel like I need to trust them with the information I can share, and they can interpret it through their lens and apply it in a way I never could, which is why I love what Dr. Seagraves has done. Like, I'm grateful that she learned something from me, but I can't do what she does. We blew that for so long. And now she's taking those skills, those ideas, and taking them to someplace I could never take it. And so I kind of am, I interpret it sort of, I don't know if I'm making my distinction here clear. I also don't know if you can hear my dog scratching at the door. I think those distinctions are actually beautiful. And I understand, though, I want everyone to hear, I've heard from a lot of OTs. I know that there's been some really uncool things that have been said. And, so I understand that may be where we're feeling, I don't know, I just don't want that distinction to be seen as a negative, I guess I don't see it as a negative. I see it as such a positive that I can offer you something and you can take it and use it in ways I could never imagine. And I can take what I learned from you and do the same. And it would be tragic if I couldn't learn from some of my OT pals around trauma, around sensory stuff. So I just think I don't want to be limited by the fact that I'm a PT, that I could go learn from other professions and specialties. So I hope I'm interpreting that well, and not twisting your words, Dr. Stover, but I think that I was hearing it through that ear, which is like, we all have something beautiful to bring to the table.
Yes. And so if we take this a step farther, right, what distinguishing yourself is beautiful, right? It is empowering others to seek the health and wellness that they so want because they know who. Distinguishing yourself is absolutely what we need to do. For instance, I have practiced long in pediatrics, and I work very prominently in trauma and sensory related trauma, right? I articulate that regularly, right? Like I talk about that and how what I am doing with my OT lens through these types of impairments and challenges faced, that is distinctly and uniquely me as an occupational therapist. But occupational therapy itself is practiced, the scope is too large. I can't practice the whole thing. PT is the same. The scope is so large. No one PT professional could practice the whole thing. So don't worry about distinguishing large professions. Worry about distinguishing yourself and the strength that you bring with the lens that you have as an OT professional or PT professional. But don't worry about if PT and OT are defined differently or how they're defined differently. I'm grateful for every single one of you in the pelvic health space. But I also know that my brain just can't wrap around it. It doesn't go there. I'm never going to be able to do that. But I know exactly who to refer to now when it's needed. I'm not going to say, well, OT can't do that, because OT can. Me, the OT, cannot. And that's where we distinguish ourselves. But I can also say, but if you have experienced trauma, let's walk together, because I can walk with you in that journey, right? So I, as the OT, can walk with you in that journey. We have our profession with us, but we're not distinguishing our profession. We're distinguishing our application of our profession's lens.
Dr. Stover, I want to introduce to you, and you may have met this wonderful human being, but Lynn Schulte, as the owner and the director of the Institute for Birth Healing. And there's been a call to action in the public recently to continuing education providers. And I'm a part of that group because I created a program that trains occupational therapists and physical therapists to practice in the field of maternal health at the acute care level. Lynn Schulte has been doing this work with pregnancy and postpartum rehabilitation, teaching both disciplines long before I was ever a therapist, to do the same thing, not do the same practice, but to actually treat the same population. And that's been really misconstrued, quite frankly, in terms of, well, you're teaching them to do the same thing. No, we're training professionals to treat the same population using their distinct, unique qualities, like you said. And so, Lynn, I'd like you to just share kind of your perspective on everything that's been said up until this point. As we roll through guests, I would love for you to have the floor now.
Thank you, Dr. Seagraves. I so appreciate this opportunity to be here, and so grateful to all of you. And Dr. Stover, everything you've said, I'm just cheering in the background here. So appreciate it. I have always felt, and I've come to this work knowing that there are so many people that need our support in pelvic health, and especially pregnancy, postpartum. I have loved from the very beginning. All of my courses have been very multidisciplined, and I have midwives coming and chiropractors coming, and it is the juiciest, richest conversation when we get together in my live courses and are able to share our perspectives together. And to me, I feel that we shouldn't be focusing in on our distinctions of OT, PT, but we all have gifts that we bring to this work. We all have what lights us up. And I want people to focus in on doing that more. And let's increase our skill set. Let's all focus on getting better at treating the pelvis and the pelvic health aspect of our work so that we can get our clients better faster, because there's way more people that we can get through into our clinic then, and we can support more clients in our work. So that has always been a goal for me with my courses, is I want to teach as many people who are interested, who have a license to touch, how to address and help postpartum women, pregnant and postpartum women, because there's enough people around that need the support. And so I just want to encourage everybody listening in, just get better at your skill set, and get better at really being able to hone in on what makes you light up, what gifts do you bring to the party, and let's share that with the world, because that's what's going to draw the right people into you. So own your gifts, own your skills. Let's get better skills in our hands so that we can do better work with our clients. And let's promote that out into the world. And you'll draw the right people to you. And know, like Julie said, know where your boundary is. Know when you need to refer out. And let's support each other. There should be no competition in this space, you guys. We all have the gifts and the skills to treat this population. So let's celebrate each other and support each other, and let's lift each other up.
Excellent. Thank you so much, Dr. Stover. Thank you so much for your time and joining us. Lynn, stick around. I'm going to bring another guest up to rotate and just add to this discussion of what Dr. Stover's up for me was a call to action, is own your skill set, own your individual practice. You cannot have all of occupational therapy. You cannot have all of physical therapy. So don't you dare define all of it for everyone. I paraphrased. That was a lot of that was mine. Dr. Stover did not say all of that. Dr. Stover, thank you so much for your time. Lynn, hold on, do not move. I'm going to bring our next guest up. This is Dr. Lenice Beasley. Now, she is a doctor of occupational therapy. I would love for you to bring your camera on so I can find you, Lenice. But I have an ask for my other panel members. A lot of physical therapists probably don't know what occupational therapists do. I say that very, I'm presumptuous in my statement. I think that if we did, I don't know that we would really need this panel discussion. And so, Lenice, please add to this discussion. But any panel members, Dr. Weeb, Kelsey, want to hear from you. Any questions that you would like to ask an occupational therapist and a physical therapist joining us tonight? Occupational therapy practitioner. I'm learning.
I think, was it Lenice, did you bring it up in the chat? I think that you just brought up a fantastic question, and I'd love to hear we had some responses around, like, where does this fall out in terms of insurance reimbursement? So I don't know if you want to hit on that a little bit. I don't know.
Yeah. So the part of the reason why I asked that question is because I think the distinction is insurance is a large part of why we kind of need somewhat of a distinction, because we all know insurance is not going to pay for two people doing the same thing. So there has to be some type of balance in what approach is OT taken, what approach is physical therapy taken. And I think I saw in the chat, someone said that they have to PTs and OTs have to document that they're providing different enough care. And I think that is why it is important for us to somewhat distinguish what it is that OTs and PTs have to offer in the same space if they're both treating the same client. But I am loving what I'm hearing tonight, just even as a clinician going into pelvic health for the first time. I'll be starting my first full-time role in pelvic health in September, but I'm not new to being a mom, and I've been out on that side of it, being able to give birth at home and just kind of face the challenges of healthcare as a Black woman, and knowing what I need to advocate for both myself in the future and even for other patients, and kind of giving them the tools that they need. And so I think a large part of it too, in terms of occupational therapy and what we kind of bring to the table, is just that advocacy and education component, even if it's just on a community level, starting with kids, I mean, as young as 13, 14, just even understanding what a cycle is and how to track things like that, and really working to make sure that our patients have the tools that they need to be able to request the services that they need. So I just really love the fact that we're talking about this, and I'm getting a better understanding as I go into the field on what I have to bring to the table and how we can work more collaboratively in this space.
Well, and I think you bring up a really nice point too, that maybe, and maybe Kelsey, you could maybe speak to this really well, is like, we're actually, it seems like a lot of the times, and a lot of people that are on social media are in the postpartum space, but the inpatient, which is, it's not my world, but there are folks here that it is, that's where we might have that co-treat issue, right? And in terms of distinction for reimbursement. But then when we talk about peds, there's a lot of collaboration in the pediatric world. And I'm not talking about the 13, 14-year-olds. I'm talking about like kids with significant motor and developmental and sensory challenges. Like, there's places where we similarly, they have pelvic health needs too. So, like, the pelvic health needs are not all postpartum-y in that outpatient setting. That's where, I think a lot of us have experience there. So it's like, how do we, like, so when we start to talk about some of these other populations, I don't know, like, it doesn't feel quite so, I'm going to use this word, but I may regret it, like turfy. Like, I don't know if that's the right word, but I just don't, I think that once we start moving into some of these other populations and other practice areas, that's where we see more collaborative opportunity, I think. I hope I'm making sense.
You absolutely are. I'm thinking of stroke rehab because of my own personal experience with seeing my mom in outpatient. There was definitely occupational and physical therapists involved in stroke care. We saw that in outpatient. So we saw the differentiation that we needed to kind of be careful with codes that we would bill. But I guess that's kind of, I just push back and I just say, I'm confused. Why are we confusing this in other patient populations like pelvic health?
And I'll jump on and add, like, to be fair, I worked in an outpatient clinic where I had more pelvic health training, and there was a physical therapist who had just taken one course. I defaulted to getting most of the pelvic health cases because I was more specialized and had more training. And I think that's a lot of what it comes down to. I've been in other settings where a PT and inpatient was handling all of the wheelchair fittings because the PT was the one that was more trained on it. And then in other settings where it was the OT because the OT had more training for wheelchair fittings. And so I think it's already been established across a lot of different areas that there's places of overlap where we might default to one or the other depending on the training if we're in the same setting.
Excellent. Thank you both. I'm going to bring up another OT and PT pair, Lynn Schulte and Dr. Lenise Beasley. Thank you so much for joining us and just kind of contributing to this panel. And as I queue up these next guests, as always, please put your camera on if you know you're on the panel joining us tonight, Dr. Licati. I'll bring you up first, and panel members, just to kind of like keep fueling these questions in my mind. If this is more of a reimbursement issue, if we're getting into kind of hot water, I just want to know from your personal experience, have you ever co-treated with another person of the opposite discipline, of the sister discipline? If you're an OT or if you're a PT, have you co-treated on a pelvic health specific case with that person? Because we could talk about other, settings. We talk about neuro, we talk about cardiopulmonary, inpatient, outpatient rehab, all of that. Specifically, outpatient pelvic health. Has anyone on this panel or our guest coming up co-treated with another discipline?
I definitely have in outpatient care collaborated where we were on the same. And honestly, it worked out beautifully because of the insurance reimbursement. They were limited to like 30-minute appointments. And there wasn't enough time in 30 minutes a piece to get through everything, right? And so physical therapy was working more like we collaborated, we met and made a plan of, hey, this is where your strength skill set is, this is where my strength skill set is. I was working more of the nervous system regulation. I was doing the internal work because I had had some more trainings on some of the things that they needed. And there was things more higher, like along the spine, that the PT was more familiar with. And so we would flip-flop sometimes who got first, but they'd come in for a full hour and see both of us.
Yeah. And that's where I started, and being able to, especially starting out, you don't know the entire scope. The pelvic health scope is so broad, right? There's so much. So I had my initial training and I treated what I felt comfortable with. And then I was able to refer out, and we were able to focus on our strengths. And, when you go through, I teach this to people that are getting into pelvic rehab. There's a lot that we can be addressing that can really help move the needle forward. We don't have to do it all at first, and we don't have to be like experts at all of it at first, but we can start to treat what we know and what we are familiar with, and then we can layer that on, and we can also refer out.
So I want to pose, this is Dr. Licati, thank you so much for joining. Nicolette Morgan, thank you so much for joining. I want to just kind of switch gears a little bit, because we're kind of we're coming to an understanding, I think, from just this panel and the discussion with Dr. Stover, is that there's plenty of room for collaboration, and there's plenty of distinction within our own individual practices. It's really quite unfair, it seems like, to really paint with a broad stroke the OT profession and the PT profession in terms of what our individual roles are, if we know, as pelvic health therapists, we may not be comfortable walking onto an inpatient rehab unit and maybe treating someone with a C3 spinal cord injury. We know that we can't speak for the whole profession on care of that population. So why would we do it with any practice, right? And so I want to hear from our new guests in terms of access to care. I'm very sensitive to this, right? I work in maternal health, and I see the disparities of just someone who looks like me versus someone who may look like some of my other panel members. And so in terms of access, we know that siloed practice hurts those that are people of color, those who have not the best in terms of income or access to care, those in maybe rural populations, all of that. And I want to know from these two guests, what are ways that we can actually work together and collaborate and increase access to pelvic health care?
I really like this question. So I work in acute care specifically. I don't work in outpatient. And one of the reasons I really like acute care is because I feel like it is an equalizer setting to a certain extent compared to some of the other settings. I mean, there's still, of course, disparities in care in any healthcare setting, but acute care is the only setting where, at least in the US, they're required by law to provide care, even if you don't have insurance, right? Even if you don't have ability to pay. And that is not true for outpatient or inpatient rehab settings or SNF settings. So I work with patients, including in the maternity unit and the antepartum unit, who don't have insurance, or who have, or who are homeless, or who are never, ever going to be able to follow up for any kind of outpatient care after they leave the hospital, whether that's financial or logistics, or because they live out in the sticks and it is 2 hours to get to even a small clinic that doesn't have specialty providers. So I think that like Dr. Weeb said, that acute care has been kind of a blind spot in pelvic health for a long time. And waking up to that and starting to provide more education around the value acute care practitioners can bring to pelvic health clients if they just had the appropriate training in it, so that we can start to catch more of the people that are falling through the cracks right now in a system that is behind a paywall, basically, for a whole lot of people. And acute care, it does have shortcomings, but it maybe has a little less than that. I also think that, because I know Dr. Weeb said she teaches, right? You teach at a school too, right? And so encouraging more collaboration in our training programs, I think, would be helpful. And not just with words, but also having other disciplines come talk to you or requiring students to shadow other disciplines during their clinical rotations. I don't think in my program in PT school, we had anyone that wasn't a PT come talk to us. And when I did my clinical rotations, I was encouraged to get in on surgeries for people I would see post-op, but I was never encouraged to shadow a nurse or an OT or a speech therapist or a dietitian or any of these countless other people that are critical parts of my patient's care journey. And that means that what those other disciplines do is a little bit of a mystery to me. And if I don't know what you do, it's harder for me to be collaborative and to think of you, right? When I'm thinking about the problems my patients have and how could we solve them for people, right?
Thank you, Dr. Licati. Nicolette, will you please speak to that? Is this more of an issue that not enough pelvic health physical therapists know what occupational therapists do as a whole? Is this more of a maybe lack of information issue?
Yeah, I definitely agree. And I'm so humbled to be a part of this discussion because I've been doing this for 3 years. I've been practicing for 4. So I'm a relatively young therapist. So to be amongst all of you is just a very humbling experience. I trained like Laura, like with a bunch of PTs. So I think it was really easy for me to spot the difference of where I was falling short. And I think it made OT advocacy just a little bit more challenging because the PTs I trained under had their systems. But then once I started to find my groove and like lose that imposter syndrome, I could tell that patients like appreciated my lens or my approach. And it created a much better environment for everybody, including myself as a relatively young woman therapist. My just to speak a little bit to what Dr. Licati said as well, I think it is so important for us to get in the acute care space because I think at the end of the day, the patients don't care really if you're a PT or an OT. I do mention it because sometimes for insurance reimbursement, it is helpful. OTs have their Medicare like numbers that they can spend in the year. So if they want to see me for their pelvic floor, sometimes they won't go to PT because they're afraid they're gonna overlap or overextend themselves. So I do mention to them I am an OT if they, want to use their Medicare dollars somewhere else for PT for maybe their low back. Like maybe PT can focus a little bit on that. OT, I can focus a little bit differently with the pelvic floor. However, that being said, I have a really cool position right now where I work in a urogynecologist's office. So my access is much more than it was in private practice. I mean, now people can pay with their in-network insurance to get pelvic floor therapy. I'm providing the care, so I know they're getting pretty good care. And it's 45-minute individual sessions plus hour-long evals, which is really unheard of in the outpatient setting. And I have really super supportive doctors. So we are working to start a program to like speak to women after they give birth the same way a lactation consultant would as well. Also, Carla Ellers, I see your comment. Low back does need pelvic health OT. Totally agree. But from an access standpoint, if someone is maxing out with me and low back is what's left, then maybe a PT could guide them that way if their pelvic floor issues are resolved.
I want to invite. Yeah. Oh, I'm sorry, Nicolette.
Sorry, just to finish that, I think it comes down to educating the patients on what OTs or PTs in pelvic health can do, so that they can make that decision for themselves.
Just a base, and Nicolette, I'm kind of going off of what you just said about the low back pain, and that I know that was coming from Carla as well. But I want to invite my panel members on this because there was just a recent pushback on branding, branding of OTs, and it's a fair question. I would say what the pushback was that physical therapists can treat or address ADLs too. Physical therapists can address mental health aspects too. Physical therapists can address a kind of a number of things like the biopsychosocial model of practice too. And so in terms of differentiation, I do wonder, would PTs be okay if OT said we can address gait impairments too? We can address low back mechanical pain too. Is that okay to just say that, we can adopt these things that historically we've attributed to each discipline? Is that okay? Panel members, what do you think?
I say yes and no. I say yes, good for you for seeing and letting your clients guide you to what they need, right? And seeking out that additional training to be able to step up to what their needs are. And I think that's why it's so hard to differentiate, because within our own scopes of practice, we have, we follow our passions, we follow our clients' needs differently. So, between one OT to the other or one PT to the other, you're going to have differences. But also I would say, a little pushback in, well, how well are you treating that, right? So one, even if I hear that, it almost devalues what I'm saying when I say I have an occupation-based approach, or whatever it is that I'm justifying my scope or my role in. I feel like that just devalues by saying I do that too. But also, how do you do that? You do that differently. You do that from your lens, not from my lens. And I think we need to be respectful in what our very specific skill sets are.
I'm open to just seeing what other people say on this, only because we just heard Dr. Stover, really encourage us to not distinctly put the profession into a box. And so if there's a practitioner that says, I do that too, she says, then market that. Market it as, your practice and part of your practice, and then tell us about it, write it down. And so I really want to just kind of, popcorn style. Dr. Tara, thank you so much for joining us, but please add to this discussion. Kelsey, Laura, Dr. Weeb, is it important that we distinguish our individual practice apart from our profession? Is it okay that PTs say we address self-care and ADLs and biopsychosocial model too?
I want to hear Tara first before I pop in.
All right. Thank you. Number one, thank you so much for having me on the panel. I really greatly appreciate this. I've been a therapist for 36 years, so I have dealt with and collaborated over the years with physical therapists, and have truly enjoyed this collaboration through these years with physical therapists. I think it's very important to know our roles. I've always dealt with that, but PTs have always had my back. For some reason, I've just been truly humbled to be able, and as a profession, to be with OTs and PTs. I work in a setting in Phoenix, Arizona, where Honor Health outpatient therapy services, and there's 13 pelvic health specialists, and I am one of those. And the others are, if we delineate, they are physical therapists, but they're not referring to me as an OT. They're referring to me, and that's on my business card, is a pelvic health specialist. So I think that is very advantageous to the client. We're here for the client. Client-centered is what we should always be focusing on. That is what I do every day that I come to work. My mind is on the patient. And that's the way I feel that no matter what your role is, whether it be occupational or physical, you need to be client-centered first.
Any response to that, panel members? That was a mic drop. I'm just going to just say it out loud, because there's no way I can do it. Mic drop. What do you guys think?
I mean, that is so good, but I'm also like just intrigued and kind of maybe devil's advocate a little bit from the other side. I can understand why it would feel uncomfortable for anybody along the spectrum of professions to get like when I hear a physical therapist say that they practice biopsychosocial or ADLs, implying that it's the same way that I'm treating it. I'm like, well, like it makes me ask questions. In the same way, I would think that, and please, PTs, correct me if I'm wrong, you might be given pause if an OT is saying I'm treating low back pain in the same way, because I think we're coming about it from different lenses, and that's okay. And are we communicating that to our clients? Because I think that's our ethical responsibility. We treat similar or same different diagnoses but we have a lens, but because we also do have very broad scopes, like I know like Lynn Schulte specifically, like very, very trauma informed, and she's a physical therapist. I don't want to limit her practice and her excellence that she has within her trauma informed care that OTs might look at and be like, well, that's our area. So like there is definitely area of gray that Dr. Stover mentioned, but I'd be curious to get other people's input of something along those lines.
Can I just take a step back and just say, Caitlin, you just joined this discussion. For me, I guess I'm like, I have to just go back and just peel back the layers. Like, how would you approach a pelvic health client? And we can really just go really broad or just really specific, but just as an occupational therapist, I feel a little bit outnumbered on this panel already. All of you, except Dr. Weeb and myself, are occupational therapists. Can you just break it down, Caitlin, for us? What does that look like in terms of a pelvic evaluation, and how would a patient know of who they need to see, whether it's a physical therapist or an occupational therapy practitioner? How would a patient know of who they need to see?
Hi. So I work for a global healthcare or a healthcare company all through Connecticut, where our referrals just say refer to pelvic health, OT, or PT. So essentially, the client picks their provider based on availability and location. I do get calls to my office about my doctor said I only need to see pelvic floor physical therapy. What is occupational therapy? So I do spend a good amount of time fielding those phone calls and explaining what my value of as an occupational therapist is. Also with the training currently, like Laura's class is amazing, but I personally felt very overwhelmed at the Herman and Wallace class because it was such a different lens than what I'm from. It just was explained in a way that didn't quite resonate with me, whereas I'm trained also in my athletic background. So Julie, I had a lot of training with you through Brianna Battles, and then Lynn, I've done a lot of her classes. Those have resonated from all my different perspectives. So I guess the thing about OT that drew me in is that we're looking at each client through what their life has been for them. What are their belief systems? What are their values? What's important to them? And that's the same way I'm looking at my client, is through my OT lens. What is my personal experience? What are my specialties? And how can I bring that to each client that I see? So when I do an evaluation, it's much different than how it was outlined in a Herman and Wallace evaluation. I do the COPAM, or the Canadian Occupational Performance Measure, where I really look at what the clients feel like they're having difficulty with, what are they not doing, and how is that impacting their ability to live the life that they want to do? How is their pelvic floor problems impacting their ability to raise their children or interact with society or complete the work that they need to do? And that's how I'm really digging into that first. And I'm spending a big portion on that before I'm even looking at the biomechanicals of what is going on with their body. What is their pelvis? What is their pelvic floor musculature? What is their perf score? I'm looking at how is that impacting them as a person first. And then I'm addressing the other parts second. And that's my scope. Whereas PTs that have shadowed me, that doesn't quite resonate with them. And they like my perspective of it, but they're not treating it in that way. I do a lot of education. Hands-on, a lot of times comes second. I'm really looking at how this has mentally impacted my client. So I do a lot of nervous system regulation. I'm a Reiki practitioner. I do a lot of that with each client. And that's my scope of practice. But it doesn't always resonate with certain people. And again, knowing my scope and my specialty and when to refer out to some of my colleagues or other professions when we're not getting the outcomes that we need. That is the most important thing. We don't know it all. My whole career, I've worked with PTs. I love them so much, but I'm not a PT. So sometimes when it is just a little bit outside of my scope, just knowing when to refer them, and vice versa. I get a lot of referrals from PT. That's like, girls, they need you right now because you're a little bit wonky or you're a little bit crazier. Okay, then come on over to me.
Dr. Weeb, I want to put this out to you just as the fellow PT on this panel. And I think we do have a representative from the APTA who will be able to join us for the end of this discussion. So I'm really excited about that. But just based on what Caitlin, said, I'm kind of really understanding that we're getting away from really defining the professions as a whole, these two disciplines, these large, professional organizations, and trying to put them in a box in terms of how they approach pelvic health. But from your standpoint, you had a lot of questions at the beginning of this. You wanted to ask a lot and just learn a lot. And so as you hear more OTs and OT practitioners and pelvic health therapists and physical therapy speak, are you getting the sense that, if a person has an experience with someone, do you think that it's our human tendency to then label the whole profession based on that person's experience? And I'm speaking specifically, if it's a good experience with an OT practitioner, do you think it's our tendency as maybe physical therapists to say, okay, well, that is what all of occupational therapy does. That's kind of that labels them for us. And on the other hand, they have a bad experience with an OT practitioner, we're going to say, well, OTs really shouldn't be practicing in pelvic health. They can't do that. Are we taking individual skill sets and painting a profession with them? What do you think?
I can only speak for myself. And I know that that's not how I would interpret it if I heard about someone, because I do tend to see people. I tend to be like the 7th or 8th practitioner that they've seen. Usually that training has been mainly physical therapists, just because that tends to be who refer, it seems, in my profession so far. And I often, they've gotten them here, but their goals, and I actually loved everything that you said, Caitlin. I was like, because I actually don't think that I treat in a way that reflects traditional physical therapy. To be quite frank, I don't fit in any box related to how we normally do stuff. And part of that is through my experience, I learned if I get ahead of educating someone about what's happening with their body, me telling them they need to do this exercise, we don't get anywhere. And so, if I don't sit and listen to their story, their whole story, and then I can start to put some pieces together of that story for them and understand them as a person, then if I don't make my physical therapy program look like their goals, like their occupation, like, why come to me? Do you know what I mean? And so I think we have unintentionally usurped, like, occupational therapists, you got to functional way before we did. And I think I shared this with Kelsey before we met tonight, but like, I did my TDPT with DOTs. Like, it was whatever. We were all in the same cohort. And so I was exposed to OT literature, and I was like, oh my gosh, this is so awesome. I loved seeing how the brain actually reorganizes around function and application of strength more than if you just strengthen it. So if the PT perspective is let's just strengthen it, or let's just look at it in a biomechanical way, I'm not interested in being connected with that. I'm interested in trying to understand it more globally. And some of that is experience. Some of that is learning from OT. Some of that's learning from neuro. My teaching partner is a pediatric PT, and it's awesome because we bring so many different pieces of the puzzle. So I don't think, and I think maybe this goes back to what Dr. Stover said at the beginning, I don't think anyone represents the profession. Like, I think we all do, and then we don't. You know what I mean? Like, when people tell me, or my parents, or somebody says, well, the PT says this, and I'm like, oh my gosh, a hot pack is not going to solve this problem. You know what I mean? Like, and if that's how you're defining PT, I don't want to be defined like that. So I guess I don't, Rebecca, I'm not sure I'm answering your question the way you want me to, or not that you want me to, but that I'm understanding what you're asking is that I don't want anyone to define me by someone else's skill set. I want to be defined by you coming and meeting me as a person and with the skills that I have to offer you. But what I want to say is when I'm that 8th person, I tell them they all loosen the ketchup bottle for me. Like, they all, like, if they're like, you're the only one that got me better, I'm like, you know what? I'm glad my skill set met your need in this moment. Like, all of those other people had something to offer, and maybe they got you more familiar with what your pelvic floor was. But now I just taught you how to apply it. So, I try not to negate the experience or the contribution of anyone to someone's, but I do not like it when folks continue to do the same thing and it's not working. And then they stick around and they stick around. Like, that doesn't make sense to me. So if someone's not improving under your care, you absolutely should be rethinking what you're doing or send them on. I don't know if I answered your question.
I mean, I think you did. I had a personal conversation with someone that I really respect in the physical therapy world, who served on the Academy of Pelvic Health Physical Therapy, and she did not have a positive experience with occupational therapy practitioners within pelvic health, and it kind of tainted her mind to say, well, maybe they're just not trained, and they being the whole profession, and I had a knee-jerk response to that. I had that knee-jerk response that Dr. Stover was really calling to action. Be careful, of how we label our organizations and our professions and our disciplines by the actions or the knowledge or the skill sets of our individual members. And so we do have a representative from the APTA here joining us, and I'll bring her up in a second. But, Jessica Dobson, I would like you to just kind of drop the mic on this whole conversation. For me, the reason why I decided to put myself out here and really kind of, host a talk, which I know was on shaky ground as it is, was because I'm looking at the access to care issue. I'm the only, probably one of the only women of color PTs in my PT graduating class that, that sits with me, that, despite all the recognition and the certifications and the board certification, whatever it is that I pile on my name, I'm going to be treated differently than my fellow panel members here, and I want better access to care for people in my community. That's it. That's where it stops for me. And so I would love to move past this conversation because it's not really where I want to spend my time. So I really would love for you to just give your final thoughts. How do we expand access to pelvic health care?
Thank you. And thank you for allowing me on this. I'm so excited. I love your question because that's the answer, right? Like, how do we move forward? And when I sit here to think about that, I have all of those patients who have walked into my office with their heads hanging low, their defeat, just like Julie is saying. Some of these patients, I'm their 8th person, their 7th person. They are disappointed in healthcare. They are medically gaslighted every single day. So while we're here debating how we should define things, there are people silently suffering. We haven't even brought up men's healthcare. Like, I haven't even heard men in here. I don't know many therapists in my area that treat men. Was I best equipped to treat them when I started? No, but I chose to learn more because the needs of my community demanded that. And so I think if we look at the big picture, who is this about? It's the clients. They're who matter, because if without them, we don't exist. It doesn't matter what we feel or think about. They're the ones who are going to decide if pelvic health is even legit. So how are we going to move forward if we don't find ourselves collaborating? I do nutrition education because my community, I live in the South, the nutrition education is horrible. And I saw the need of clients with gastrointestinal issues coming day after day, and no one was asking them, how much water do you drink a day? What's your fiber intake? So I went to go learn functional nutrition to help serve my pelvic clients. I learned trauma-informed care to help all of those clients who came in defeated. So we are individual. I think we know that. And I think we just have to keep saying it, like, say it proud, do what you do. And advertise that. Your pelvic health therapist that specializes in digestive health or postpartum, or you serve men, because there are enough clients. There are enough of us we can collaborate with, and it's going to look different in every single setting, every single state, every single community, because the needs are different. We are not the same in every place that we are employed. It can be a collaboration, PT and OT. Or it can be the PT that specializes in postpartum return to running. It can be the OT that does trauma-informed care. But if our clients don't know what we have to offer, they don't know what to ask for.
That was powerful, Jessica. Any panel members, if you want to close and kind of give your final thoughts, what would they be tonight?
Jessica, I just wanted to really highlight something that you said there You're, talking about if we actually treated everyone who needed pelvic health services, we're at a loss. We have a capacity issue, right? That is the real elephant in the room. And we do need all hands on deck. And, like if, I look at the federal bill, HR 2480, Postpartum Outcomes Act. And, what I'm hoping is to see next steps where we can all kind of collaborate and work together and be writing these things together to include OTs under the pelvic health services definition. But honestly, if we get that passed, we still can't actually meet the demand. So we need to first really kind of unite and be able to inspire more of us to get involved in this work, to be able to understand that we can incorporate this work even as general therapists or in whatever across disciplines and practice settings, and really as Jessica McKinney is one of my mentors, as she says, reimagine how we deliver healthcare.
Excellent. Thank you so much. Dr. Mamawa Bork, please introduce yourself. And I'm sure many of my panel members, as well as myself, want to just ask you a question and hopefully not put too much pressure on you, but we're really excited to hear from a representative from the Academy of Pelvic Health of the APTA, and just in terms of how can we collaborate together across disciplines to expand access to pelvic health care. Thank you and welcome.
First off, thank you so much for inviting me, Dr. Seagraves, and I'm just so honored to be here, and I think this is just a powerful conversation that needs to be had. Again, my name is Dr. Mamawa Bork. I am a pelvic floor physical therapist, and I am one of the Southwest region representatives, and so when she asked me to come on here, I just thought this was really necessary to really talk about how that looks. And the first place I thought of was in inpatient rehab and how much better our patients get when we combine services versus when we work in isolation. And pelvic health is a space that has evolved from initially being so pregnancy postpartum focused to pelvic health focused, and that is the aspect that we really need to look at globally. And there's aspects that OT are very strong in, PTs are very strong in, and together we could make such an impact in how our patients' outcomes are. Just like if you have a patient that is walking, in their home but cannot cook anything, they're going to have issues if they've addressed it in inpatient rehab or we're struggling to get our patient to walk. Some of our OT counterparts usually have a different approach or technique that like everybody was mentioning, brings in the function that turns on those certain aspects of care. So I think what it is one, having conversations like this. And the more we start to normalize collaborative care and stop working in isolation, I think those are the things that are really going to help. Collaborating with AOTA and APTA on pelvic health related events. So for instance, if we're going to do things where we are speaking on endometriosis, we don't need to be speaking on endometriosis in from one lens, just like we just say whenever we have a speaker come up, it's usually like pelvic health provider, but really, expanding on that and explaining that this is an occupational therapist and how their function works in it. Because sometimes I feel like OTs feel as if they are, a second thought when it comes in and like I mentioned, inpatient rehab is the best example I can give, where they go, oh, have they had OTPT? And then they're like, well, they cleared PT, who cares if they've had OT? And it's like you're missing such a huge aspect of care. And because of the fact that we're not just speaking on pregnancy postpartum only anymore, we need a bigger lens to look at. And it's time to start looking at things more holistically, as we say we are in pelvic health. And that includes being interdisciplinary when it comes to OT and PT, collaborating in clinics, in the hospital-based systems, in the outpatient systems, and the home health care systems. So it's not just in one aspect of it, but in different aspects, in education, in I think Herman and Wallace does a really great aspect of allowing both parties to be involved. And I think that's what the AOTA and APTA need to do a little bit stronger on when we do, when we host events, when we host educational events. Let it be a more interdisciplinary invitation. So
Dr. Borg, thank you. Yeah, no, that was wonderful. I want to ask you this because Dr. Stover she invigorated me with the understanding that we are the AOTA, we are the APTA, those of us in our respective disciplines. Do you feel like your voice is heard on this issue as a representative of the Academy of Pelvic Health? Do you feel that other colleagues of yours feel the same way, that there should be more of an interdisciplinary practice within pelvic health care?
I think the conversation is still very novice, and where people feel like there's an elephant in the room when they have the conversation, where people are hesitant to ask the question from an understanding standpoint when it comes to understanding how OTs help support pelvic health and how they navigate pelvic health. And so that becomes a barrier. And so I think though having these platforms where we can have open conversations would allow for more to increase awareness, to increase understanding, where we can speak positively and advocate for each other, having a space in there. And the more we do this, I think it'll improve. So yes, I do think that it's a thing that is becoming more prevalent, but I don't think we're there yet. Just like pelvic health isn't there yet, this is another element of pelvic health that really could use growth.
Interdisciplinary practice. Thank you so much on that. Absolutely. And I agree. And I want to invite Kelsey really to take this moment with you, Dr. Borg. And I want this engagement to be almost like a way to communicate with a larger audience. But I would love for her to take you through a position statement that was published this year. And already the shout out to Dr. Carlin Rayum and her team for writing this and putting the scope of practice on paper. And so I'm going to share my screen, but I'm going to have Kelsey take the reins and actually going through just some of the major highlights for you, and maybe us ending with how we can bring this to the association level so that members of the APTA are even aware that there is this document, this living document that was created, and it's only just the beginning. Okay, so let me share my screen, and Kelsey, please take the reins once you see this up on the screen.
And while I'm waiting for it just popped up, but like we have that top to bottom and then bottom up approach, and I think right now we got to take both. And we have so many people who are going bottom up grassroots level, doing the thing, getting it out and the word out in the community. But we have to have that top down approach too with getting the word out. And I think you touched on it so well, that awareness is a large part of the issue. And so kind of like a call of action as we're talking tonight about like, where do we go from here? Is there anything we can do from like a top-down approach to help get the word out? And we took the wonderful work that Dr. Rayum did and the OT Association of California. They put out a scope of practice, like just a position statement, as a state of what OTs and pelvic health do. And so we took what they wrote and put it into a Google form as an open letter of support for OTs and pelvic health, just acknowledging our scope of practice as a way to kind of gain awareness and help people know, like, hey, this is what our scope of practice looks like when it's defined by one of the state's associations. And so it goes through and it talks about why support the role of OTPs in pelvic health, and it lays it out there. It talks about what is pelvic health from that OT lens, and it goes through and just gives that description that I think answers a lot of the questions that we've seen out in that social media space of, like, what are OTs doing here? What does it look like? What is their scope of practice? How do we define it? And here we go. Like, there's the definition. There's like those questions answered. And there's an opportunity, a call for action at the end of it. And it, like, again, I guess she's scrolling through, why is pelvic health important? Why are OTPs uniquely qualified? What I didn't include, but I do have the web address at the top, is if people want to look at the references, like, show me the receipts. Show me the receipts of why this is OT scope of practice. Like, it's there. There's references there. At the bottom, there's a place for you to check mark saying, like, I acknowledge and, like, I affirm, like, yes, this statement is representative of what OTs do in pelvic health practice. And then a place for you to type your name. Just be like, yeah, like, I'll put my name to that. I'll put my name to that. Like, this is a description of what OTs do in pelvic health, so that we can hopefully gain some momentum. Just like open letter, letting people out know, like, hey, we've got the documentation, we've got the receipts, we're here. This is where it's at.
I love this. I think this opens up a lot of the conversation that people, well, it answers a lot of the conversations that people are having, like side conversations, like what does an OT do? I don't understand what an OT does in it. And when you put it in this lens, it's hard to, argue that this should be collaborative. This should be a space that we're both in. So, and accepted in, because I think a lot of times people push the conversation away. So I love that you all did that. And yeah, I like it.
Yeah, pass it, share it around.
Yeah,
well, exactly that. Like, if you could please, like, share it. I think Dr. Seagraves dropped a link in the comments, and that's for all of you who are on this call. Please, like, click the link. I know that there's a couple of comments too, so we might drop it again towards the end. Like, go to the Google form, read it, gain that understanding, and then share it far and wide. Like, wherever you're at, your like social media pages, wherever you are, like, just share it out to let it know, like, hey, like, let's get the word out. This is what's going on. And like, that's a step. The national position paper is another step. Like, steps are being continuing education from wonderful OT providers. Like, there's steps that are being taken to get the word out.
Dr. Bork, I'll just end with this. And when I read this, and I just kind of, from our own profession, just know we are adamant that evidence-based practice must be at the forefront of what we do. We have specializations, whereas maybe there's not an equivalent for our women's clinical specialists in women's health, or clinical specialists in orthopedics and neurology and neurologic practice and pediatric. We really, really value written documentation of a description of this size, of scope of practice. I have to ask you, as we end this talk and really like focus on expanding collaboration, do you think that more awareness within the Academy of Pelvic Health, the section of APTA, would that be helpful to just push this document out so that they can see a position state has been written in one of the largest states in the continental US, and there's only going to be more? Do you feel like that's going to help expand access to pelvic health care and collaboration across disciplines?
I think it has the potential to. I know that when it comes to government entities or organizations, like the lens moves slowly. So I think that the more we start to have these conversations, this is like, I don't want to say a great first step, because I think that this isn't necessarily a first step, because OTs have already shown how incredible clinicians they are in the pelvic health field. So I just think this is an objective way to be able to define that people can respond and say, okay, it makes sense. I understand it. And like you said, evidence-based wise, we need to be, speaking for our counterparts, our OT counterparts, a little bit louder. And that's, I think, where I think it would go with it. And I tend to be a positive Patty. So from my standpoint, I think I'm like, yes, this is what I'm talking about. I'm a lot more like Dr. Weeby when she said, I kind of think differently than the traditional PT. And I tend to lean more towards OT. So in my head, I think like put the function in it, you know? And I think OTs do that so well. And I think people are missing. I feel like from a PT standpoint, pelvic health is the first time that what we're always working on is the function. You know what I'm saying? And that's where OTs thrive, is in the function. So it's a no-brainer, but this is a great objective way to bring this back to the Academy of Public Health and say, hey, look at what our colleagues have done, and how do we, be a soundboard for them.
Excellent. Thank you so much for joining us. Thank you so much, Dr. Borg.
Thank you for inviting me. And everybody spoke so eloquently about this. So it's an honor to meet all of you.
Likewise. Panel members, thank you for staying on just a little bit longer for this amazing discussion. Any closing thoughts as we wrap up this evening? I'm going to just say one, Pelvic Health Therapy 2025 is going to be a blast. I really think that more conversations like this happening on a regular basis. Dr. Borg already planted that seed. We need more events with both of us. We need more courses and training with both of us. We need more panels and discussions with both of us and with other providers across the healthcare spectrum, right? Mental health, pelvic health, they're all integrated, right? And so I'm going to put a call to action and say, hey, let's do another event. Let's do more of these. Maybe not make it 2025. Let's do another one in 2024 for the fall. But thank you all for joining. Any final thoughts from you all?
My only final thought is hope. Just like I live by it, die by it, hope. And just going through this conversation, I'm getting tears in my eyes. Just like I have so much hope for the future of our profession, and it's going to take all of us. So just thank you, everyone. Like so much hope going forward. I'm really excited to see what 2025 holds, as well as the rest of 2024.
I think that what I'm so thrilled that you joined us tonight. You can rep the APTA Pelvic Health Academy, but I love the idea that if we can all hold hands and our passion is for such a marginalized area of care. Like it's just, there's so little help in this area and there's so much need. And I think like if we could actually get APTA and AOTA advocating on behalf of understanding this across the profession, because we don't even have great PR inside our profession. You know what I mean? Like inside, or the world or doctors or, so I love the idea of maybe like more collaboration between higher ups that can, look to creating ways for more advocacy in general around caring for pelvic health. Like I think that we have so much power. Like this is sort of circling back to what Dr. Stover said, like we're better together. And yeah, so, amen. Kelsey, I share your heart there. Like this is a life pursuit for me. And I just want to keep moving this ball forward. Like there's too much need and we got to keep at it.
And I think we've said it all, and I think it is agreed that we are going to succeed with a united front. And we have our different entities, but I can really see us, if we have an organization or an organized effort with equal representation addressing these issues, we can really start to spread the awareness and break down the barriers.
Excellent. I echo everything, and the chat is just fired up. Better together is the theme from this evening's conversation. Thank you all for joining Pelvic Health Therapy 2024, collaboration across disciplines. I look forward to working with you all. Thank you.